Let's do around the eyes, and I want to use the 50-50 blend because I don't have the revise. So I'm going to use the 50-50 blend of either Kiss, I think would be fine. Okay, that's a softer product. I'm going to do the upper and the lower, the infrabrow and the infraorbital. Okay? Sorry? Kiss with what? Yeah, thank you. Thank you for using the word blended. I blended it with lidocaine because I'm trying to make revise, okay, which is the product that I like to use over here. I mean, to be honest with you, when I was doing these areas before, Prolenium didn't have a product that I felt comfortable with using unless I go in ahead. Because Kiss is a great product, but it has a factor of swelling of about 4 times, and I don't want there to be swelling here. So I'm giving it the drink it's looking for before it actually goes in. I'm injecting the large sponge instead of the small sponge. Remember, you used to have these little sponges. They were little rabbits, and you put them in a glass of water. You'd wake up in the morning. They were huge. They were beautiful. It was like a big toy in my day. That was it, watching a sponge grow. Okay? But what you do is you're putting in the stuff. The HA is wanting to drink water, so I'm giving it the drink rather than taking from the patient, and I have no control over it. I'm going ahead and giving it the drink beforehand. You good? Yeah, we kind of narrowed that nostril down a little bit. Okay, but we definitely got rid of this part over here compared to there. You see the difference? See light, shadow, light? That's what we pick up on, but you don't see that on this side. Okay, so let's do the upper first. You can give it to me on a 25 gauge cannula. I want the 50-50. The Kiss, okay? Sorry about the blending, Prolenium, but I can't use my revise, so I'm showing them what revise can probably do by itself. So, deep set eyes has always had deep set eyes. I don't want to change that, but what happens with maturity as we mature is that the high point of the upper lid from the crease moves from the medial aspect to the mid aspect, and that's what causes an A-frame deformity. Okay? Okay, a little more on the opposite side. You see that? So we're going to have to treat that as well. So you're going to lift your chin up, and I'm going to go ahead, and she gets me a product here, and we're going to go ahead and use it. So what I do is I come in from lateral. Thank you. Here you go. Oh, here we go with a long needle. Okay, no problem. About a 25, and I can stab her from the other room. Okay. Here's the orbital rim. We go ahead and we pinch the skin as we put the needle in, and we give it a little spin. Just like that. Okay? You good? That's a 0? Well, there's a needle hanging from you. Okay? You turn your head a little bit like this. I tense the skin. I'm holding the cannula. Oh, you found me a shorter one. All of a sudden. Okay. And then I'm balanced. She pulls it out. I find the hole. I get in, flatten out. I'm on periosteum here. The periosteum continues as the orbital septum. I slowly start to advance. Okay? Just like this. Now I go into my injection mode. I turn her head towards me. Where am I located? I'm located, you can see that I can't lift the cannula because it's on the undersurface of the periosteum of the orbital rim. People say, well, this looks very dangerous. It isn't. Your vessels are over here, they're coming out higher up. Okay, I'm going to go ahead and advance still a little bit more. There I go. If I beat a little bit of resistance, I gently put a little product in. I'm working my way all the way over to the medial canthus. Look. Okay? Now I'll start my injection slowly, keeping the plunger at the base of my thumb. I'll do a little retrograde injection, just like that. You can see the product filling. Okay? A little bit over here, a little bit back. And now we're going to see if my nurse was nice to me or not. You weren't nice. You're never nice, you're right. Here we go. Come on, Catherine. No, can't do it. Sometimes I'm able to, actually we have a little clamp, and I'm able to unhook the cannula from the actual from the actual syringe. You don't have one of those with you, do you? Nope. You have nothing that I'm going to be able to grab this thing with, huh? Okay. So, imagine that the syringe is not on the cannula. I sit the patient up, because then you can do that without having to hold it, and I take a look. Let's pan out a little bit there. Look up into the camera, and I take a look and see if there's any parts that I missed, like over here. I mark them out. I have the patient sit back down, and then I go ahead and I inject a little bit more over here like this. Very gentle, back and forth. Out I come. There's no bleeding. Here you go, Kath. Good luck in taking that cannula off. Now you gently massage. You've got to do this on your patients. It's not a difficult thing to do. You don't have to twist and turn the cannula. That means you're too deep, means you're in the muscle. Okay? You either be above the muscle or you're below it on the septum. Either one will work. You basically just do that. You do a little bit of massage. Sit the patient up, look into the camera. Yeah. Okay, just keep looking into the camera. That's what I want. Okay? To me, an older lid is a lid that has too much lid showing. But this lid, we want to be able to have the curve of the upper eye volume follow the lash line. Do you see the difference? Okay, and we're going to do that on the other side afterwards. I'm treating this area over here. As I told you, the orbicularis muscle is attached here and attached here. Everything else floats on the roof and the souf, which are those fat pads over here. And when you close your eyes very tight, you don't do this. You do this. You purse string. Close tight. She pulls everything in. Do you see that? I can't put everything on bone here because I'm in muscle, and with her blinking, she's going to push that product into a ball over here. Under the muscle here, I could work. Under the muscle here, you can't get under the muscle because the muscle's stuck to bone. So you have to understand that. So I can use a cannula or a needle here. No, I don't have to mark it. What are you giving me? You're giving me a needle? Okay, we'll do a cannula on the other side. Bevel down, lots of little veins over here. You're going to feel a little pinch. I'm down on bone. I inject slowly, and this is one of the few times that I use Gerhard Sattler's little tower technique. I inject as I withdraw gently, and I pat it down. And you just obliterated that outside part over there. You can do it again over here. A little flick, down on bone, inject, gentle injection, little tower, out you come. And it just corrects beautifully. Okay? You can see how it's just correcting everything. Now we're going to get more medial. When I get more medial, I can do one of two things. Let's see if I can avoid a little vessel here. A little down on bone here again. Here's my injection, a little bit more than I would put in. And now I say, go visit the tear trough. There you go. Like that. Okay? Open. See how we're almost obliterated compared to the opposite side? Very small amount of product. She probably doesn't need more than that because I treat to about 80%, but I want to show you the cannula technique, and she trusts me so far. So let me have the same product on a cannula, if you don't mind, 25 gauge, with a 25 needle. I'm going to try to avoid that little, what is it, a pimple or something? Are you playing with something? You don't know. Okay, we're going to try to avoid that. I'm going to clean it as best as I can. And I'll show you what the story is here. You can drop a little bit. I would be using Revise, but I'm using the same product that I did before blended. So I'm using the KISS because it's the one that will swell the least with the blending and the one that spreads and is cohesive. Okay? You can use Outline to do that too. When they came up with Revise, they basically took the thing that I was doing and they made the product. It was as simple as that, and it worked very well. And it does work very well. Do I have a blending ratio? I do, and we'll talk about that in a minute. or two, but it doesn't mean it's right or it's wrong. It's just the way that I do it. So I'll fill you in on that. Remind me. I'm just going to concentrate on this thing. I'm going to stay a little bit further away than I usually do to stay away from that little redness. A little pinch. In goes the needle. A little flick like this. No blood coming out. We're doing great. We're going to go ahead and pull this. She's going to take it out. I'm going to find a little hole. I'm going to poke in. And then the second I get in, I'm flattening out my cannula. Now I want you to see, as I slowly advance, how superficial I am. There isn't a product in the world that you can do this with unless it's blended or it's revised. Because you can't be that superficial. What I'm doing is I'm trying to imitate what we do with surgical blepharoplasty. When you do a surgical blepharoplasty, you go transconjunctival usually to take care of the fat. You either melt it, you either remove it, you either redrape it, you do whatever you can for it, okay? You don't touch the muscle, and then you do something to the skin. You either do a pinch blepharoplasty or you use laser to shrink the skin, but you leave the muscle alone because it's blinking 1,200 times a day. I'm leaving the muscle alone here. I'm above it. Can I control it like this? Do you want me to inject like this? They don't want me to inject like that, so I'm going to inject like this. Do you see that? And I'm thinking in my head, I'm not even squeezing, but I'm thinking in my head that I'm injecting. Squeeze, 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 squeeze. The plunger's probably hardly even moving. You maybe need 0.002 of product to do this. Look where I can go, right up in there, and she doesn't even blink or feel anything. And I'll come a little bit down over here. All right? And then we'll just go ahead and just gently go ahead. Open your eyes. I don't want it any more than that. Okay? That to me is already treated. She can use maybe a teeny bit more over here, Kat, if you want to go ahead and give me just a little bit more on the BD2. Or I can try to bruise her. Yeah, let me try bruising her. What you can do is you can go in with the cannula from here and then go retrograde up like this if you want. I find that every time that I try to do it from the bottom of the V, what ends up happening is that when I flip my cannula around, even if it's almost out of the skin, it can leave a little mark that they cover with makeup for a day or two. So I could go with the cannula from here, but because we started with needle, little flick, down on bone, here we go. I'm going to actually put in a little more. Withdraw a bit. I'm going to create that little bump, and now I'm just going to blend it down. There you go. Perfect. She's being very good. Supra, infra. Corner of the mouth is up. Jawline is tight. Okay? We got the tail of the brow up on this side. What I should really do, give me that same product again. I'm going to try something here. Same one on the BD2. Yeah, it doesn't make a difference what product it is. I'm going to try to show them if I can possibly, without toxin, vertically elevate this thing so that it matches the other side. Okay, whatever you have. You have some in the cannula, right? See what she's doing? She's blending it back into the BD2. Small little stick. Down on bone. Here comes the injection. Okay. Here you go, Kat. Thank you. Let's mush it up a bit. That's better. Any product. That's not helping you, is it? You could use any product over here as long as you use a small amount. Why does it work that I'm able to jack up that brow over there just at the peak? I'll explain it to you. For those of you who are sailors or those of you who have boats, when a boat cuts through the water, it creates a wake. The water pushes to one side, it pushes to the other side. When you have a brow that's sitting just a little bit above the orbital rim, if I put product in on the brow rim over here like this, and I'm pushing the rim forward, the tissue does this, right? The tissue does that. So by pushing it forward over here, it's pushing her eyebrow up. Okay? If her brow was low like mine, and I put the product in on the brow, on the orbital rim, it would push the brow down. Eyebrows, I consider them, and please don't take this the wrong way, like breasts. When we do a breast implant, if we put the implant in on the breast, and the projection of the implant is at the nipple or slightly below, it elevates the nipple by about 1 centimeter or 2. We know that. If you have the projection of the implant above the nipple, you get a fullness over here and the nipple starts to point down towards the ground. So we're doing the same thing by putting in a product or a device over here to go ahead and to lift. That's exactly the same concept that I'm doing right over here. And that will stay up for quite a while. So let me ask you a quick question, guys, because I'm going to throw this at the audience. I come into your office, and you're dreading it. I come into your office with my low brows like this, and I say, I want you to lift my brows. Okay? And you say, well, I'd love to put filler in to do that, but the brow is in the wrong position. It's too low. What do? Right. So you do your toxin on the crow's feet, the vertical aspect of it, and now your brow floats up. It's in a better position. And then you go ahead and you inject that patient 2 weeks later, and you push that brow even higher. You did great. Doc, I'm so excited. Thank you so much. Hang on a second. What's the problem? The problem is that the toxin is going to wear off in 3 months. Your brow is going to drop back down to the unfavorable position, and my product is going to make it look worse because it's going to push it further down. So what do? When I started doing this back in 2001, when I started doing this, I said, I know what I'll do. I'll use a product that melts out in 3 months, and then we redo the whole thing. How stupid was I? What do you tell the patient? That brow's going to drop. What do you have to do in 3 months? You got to toxin them again. So I tell them, if you don't want to look like this, you got to come back in 3 months, and I'll redo the toxin. Not one of those patients misses their appointment. Perfect. You go ahead and you redo the toxin in 3 months. Your product stays in there for a year, and it keeps the brow looking like this.